Hello, everybody. This is Dr. Al Heuer. I am a professor at the School of Health Professions at Rutgers University. I am an adjunct faculty at the County College of Morris's Respiratory Therapy Education Program in Northern New Jersey. I co-edit 3 textbooks in respiratory care, including Egan's Fundamentals of Respiratory Care. But I'm coming to you today for an entirely different reason. I am the co-owner of A&T Lectures with Terry Shenfield, and today I will be presenting to you on a topic related to spontaneous breathing trials, or SBTs, and ventilator weaning. I hope you enjoy this presentation, and Terry and I thank you for joining us today. So before we get into the substance of today's presentation, let's talk about the overall flow and the structure of the presentation. Let's look at the learning objectives. The first of which is we'll review some key terminology. From there, we'll emphasize the importance of collaboration. By collaboration, we mean interprofessional collaboration amongst the physician, the nurse, the respiratory therapist, physical therapy, dietary, and other related professions, all with the shared goal of successfully liberating the patient from mechanical ventilation. We'll then summarize some of the related research. We'll describe key points related to the guidelines and evidence that has to do with spontaneous breathing trial and weaning. We'll then review the inclusion and exclusion criteria. We'd like to say that all of our patients that are on mechanical ventilators are candidates for spontaneous breathing trials and extubation. Unfortunately, there's some subclasses that are simply not at the current time ready to be weaned and extubated. And we'll talk more about those categories of patients. We'll also summarize how patients should be prepared for the process of weaning and extubation and how they can be optimized. Now, optimized means how they can be kind of, brought to that pinnacle of they're so ready to go, but how they can be as the best version of themselves, given that they're probably in an ICU or at a long-term acute care facility or similar type of organization. So optimize, how they can be, positioned to best successfully extubate. We'll review and debrief some cases, and probably most importantly, we'll provide you guys with additional resources should you want to drill down and learn more about these topics. Now let's take a look at some key terminology related to spontaneous breathing trials and extubation. So the first one is what I've just alluded to, and that is a spontaneous breathing trial, where we as clinicians simulate spontaneous breathing for patients with artificial airways who are on mechanical ventilation. So typically there's a lot of approaches that you can actually take. One of them is you can actually calculate what the resistance that's imposed on the patient by the artificial airway and dial in a pressure support to overcome that. So if you recall, resistance is the difference between peak and plateau pressure divided by inspiratory flow in liters per second. So if you calculate that the resistance is somewhere around 4 or 5, you could dial in 5 sonometers of pressure support ventilation, and it would simulate or closely emulate a spontaneous breathing patient. Many ventilators have tube compensation or equivalent modes. The Covidian Puritan Bennett 980 has TC or tube compensation, where you put in various parameters, including the tube size and the amount that you want to compensate for, and it will emulate a spontaneous breathing trial. There's others as well. You can put a patient on a T-piece. The problem with that was sort of the standard of care, at least the recommendation for a number of years. The problem is it's actually more difficult for patients to breathe with an artificial airway than through a anatomical airway. The reason for that is it's smaller. So it really has to do with a diameter thing. And if you remember back to calculating the resistance imposed on a patient by an artificial airway, it has to do with the diameter or the circumference, the inside circumference or diameter of the artificial airway and the length of the tube. Hence, and I'm getting a little bit ahead of myself, patients who have trach tubes, tracheostomy tubes, tend to wean better than those with endotracheal tubes, mainly owing to the issue of the length of the tube. There may also be some psychosocial things, like the patient may just be in better spirits because they can eat, they can speak, they can have better mouth care and things along those lines. But the main driver there is that the length of the tube, the trach tube, is about 1/3 the length of the endotracheal tube. The standard of care is still to do this for 30 to 120 minutes, so 30 minutes to 2 hours, if they can tolerate it, of course. If they show signs of distress, the patient should be returned back to full support, to assist control or pressure regulated volume control, dual mode or whatever your full support mechanism is. That's pretty much the standard. What the more recent data is showing is that you're going to pretty much know in the first 30 minutes or so. So while it's not irresponsible to do it for up to 2 hours, it's for a lot of patients, you're going to know they're going to tolerate it. If they do in the first 30 or 40 minutes, there's a good chance they're going to tolerate it longer than that. And then another term is weaning parameters. So these are measurements or metrics used to determine readiness to wean and hopefully extubate. And there's many of them. Included amongst them is a NIF. So, our NIF, so if we're otherwise healthy adults, you would be negative 60 to about negative 100 or more. What's minimally acceptable is a NIF of in the mid-20s, 20 to 30, 20 to 25, depending upon what guideline and textbook you actually read. Vital capacity, so vital capacity should be, for a normal person, would be like 65 or 70 milliliters per kilogram, but what's minimally acceptable is about 15 milliliters per kilogram, or about 1 to 1.2 liters. Sedation holiday or sedation vacation is often coupled with a spontaneous breathing trial. So you wake the patient up. You aim for a RASS, R-A-S-S, or Richmond Agitation and Sedation Scale, for right around like -1, something along those lines. So they're totally arousable, maybe a 0, but they're not agitated. They're not, they may still have some sedation on board, but it's certainly cut down significantly. Maybe turned off altogether. The problem with turning it off altogether is some patients will go to the opposite extreme, and that is they'll just get very anxious. They'll breathe very quickly, but it's not really because of respiratory causes. It's because of other causes. Rapid shallow breathing index, some argue, is another weaning parameter, where you're looking at the spontaneous respiratory rate as the numerator, as the top number, and then the tidal volume as the denominator, expressed as a decimal in liters. So, if you have somebody who's able to spontaneously generate a tidal volume of 400, and their respiratory rate is, let's say, 25, so the numerator, the top number, would be 25. The bottom number would be a 0.4, and that number is going to end up being like 62, 62.5. Again, it's 25 divided by 0.4, which works out to, if you want to round it up, it's 63, considerably less than the cutoff threshold of 105. So, what you really want to see is that RSBI, or rapid shallow breathing index, being less than 105. The closer it is to 105, the less good it is. It's also problematic if it's extraordinarily low. So you get patients sometimes that are waking up from sedation. They're not quite awake. They're pulling these really robust tidal volumes of, let's say, 800, 900, 1,000, but they're only breathing at 6 breaths per minute because they're not fully awake. So their RSBIs will be, in the teens, extraordinarily low. They may, in an hour or 2 or 3, be very ready to be, weaned and extubated, but they're not quite ready right yet. So we're typically looking, for an RSBI between like 20 to 25 and about 100 to 105, something along those lines. More definitions here. So diaphragmatic fatigue. So if a patient is, if we work them too hard, if we put them on 6 or 8 of pressure support, and their RSBI is approaching 100, 105, so they're chugging away with respiratory rate, well in the 30s, a tidal volume that's maybe 250, so ending up with a RSBI, again, that's in that low 100s type of range. What we can do to them, we can actually set them back. We can give them diaphragmatic fatigue. And what we know is that if we work a patient too hard, too fast, maybe a patient who's been mechanically ventilated now for a couple of weeks, and we're pushing them too hard, too fast, the diaphragm can get fatigued. Of course, the diaphragm is the main muscle of ventilation, and we can set them back days. So the bottom line is, or if there is a single bottom line, one of the bottom lines of this presentation is you want to try to get the sweet spot between diaphragmatic fatigue, which you want to avoid, and diaphragmatic atrophy, which is the opposite end, where we're not working them at all, type of deal. And there's different techniques that you can do that we'll discuss in this presentation. So the diaphragmatic atrophy I just kind of defined in the context of comparing and contrasting it from diaphragmatic fatigue. Alveolar derecruitment, so may occur when a patient with an artificial airway is breathing at a low tidal volume and or a low PEEP. So one of the issues with the using low tidal volumes, as we started doing about 25 years ago, is we find that there's less a chance of what we call iatrogenic lung injury, where we caused it. We set too high a tidal volume, where there was shearing pressures or shearing forces. Those shearing forces cause an inflammatory cascade, et cetera, et cetera. So we use lower tidal volumes. What we found, though, is that we do get an element of atelectasis and alveolar derecruitment. So it's important to be mindful of that phenomenon as well. Recruitment maneuvers or RMs using short periods of high PEEP, perhaps 30 centimeters for 30 seconds, or other open lung strategies. APRV or airway pressure release ventilation combined with a drop-in stretch approach, where you're dropping the P high, you're lengthening the P high, and you end up basically with with PEEP and pressure support. There's other techniques as well. There's actually recruitment maneuvers where you use only intermittent APRV, where you use like basically 7 or 7.5 seconds at P high of, let's say, 30 or 35, and then an equal 7.5 seconds at P low. So that's not APRV. Obviously, the P low and the T low is very short, often about a half a second. But when you're using APRV for a recruitment maneuver, you're typically, you have your T high and your T low are equal, but you're only doing it for about 5 minutes as tolerated. So recruitment, there's a lot of different approaches that can be used. The latest evidence is saying is really pointing closer towards using an APRV-like approach. But again, the 30-30, in some cases 40-40, that is 40 centimeters of PEEP for 40 seconds, as long as the patient can tolerate it and they're not hemodynamically unstable, those can potentially offer some benefits. Wean per physician order, so weaning a patient outside of your hospital's weaning protocol. So it may be like 4 hours on pressure support, 4 hours on assist control, something along those lines. The evidence to support like a 4 and 4 is not that strong, but anecdotally, some places seem to be using it with some success. Turning our sights for a moment on the research that's been focused on predictors of a successful weaning, hopefully successful liberation or extubation from mechanical ventilation. Rich Calais and others did a systematic review. And I just want to point out, so this one was actually indexed in the Cochrane systematic review. So if you see a systematic review that has Cochrane, if it's been accepted in the Cochrane database, it's pretty much bulletproof. It means that it has adhered to best practices. It means when you read the article, it's something worth paying attention to and perhaps using it combined with other research to formulate any policies and procedures or protocols that you're looking to put in place. And what Rich Calais, Rich is now, he was one of our colleagues on Egan's Fundamentals, who's very well published in Respiratory Care Journal. But what he actually determined was that spontaneous breathing trials combined with conservative sedation practices were associated with both reduced ventilator days and overall reduced ICU length of stay, LOS. Burns, earlier on in 2014, determined that automated weaning with SmartCare. So SmartCare is software that will automatically wean the patient, basically looking at a bunch of different parameters simultaneously. And using these computerized algorithms significantly decreased weaning time, ventilator days, and ICU stay. Now, I will tell you, in countries outside of the United States, in some cases, the weaning can happen automatically, literally through an interface. It will determine that criteria has been met. It will reduce the pressure support, etc. As of now, in the United States, the Food and Drug Administration says, well, we're okay with SmartCare. It just can't be an automatic thing. There needs to be a human being involved who has the licensure, scope of practice, and internal authority in order to write the order to reduce further. It can't happen through a computerized algorithm. So it's just something to be aware of. Whereas we do things differently, obviously, than other countries, and in this country, that's what the FDA said with computerized software like SmartCare. Baptistella and others in 2018 also published a systematic review and looked at the RSBI, the Rapid Shallow Breathing Index, was the most frequently studied and an important measurement tool in deciding whether to wean and extubate a patient. So it's certainly in that mix, one of the more prominent criterion that would be used, but hopefully used in the context of other indices as well. Sometimes you can get patients that have really crappy RSBIs, but the main reason why they're breathing so quickly and skewing their RSBI is because they're anxious, they're too awake, or they're in pain. So the RSBI is good, but it's not foolproof, and it needs to be used appropriately in the appropriate environment and context. Kutak and others in 2017, they determined that the inability to follow commands, hand grasping, or thumbs up, stick out your tongue, etc., independently predict extubation failure in critically ill neurological patients. Just to be clear, it's a subset. It's a specific subset. Neurological patients, their inability to follow commands was singularly a predictor of success. Obviously, the other criteria needed to be met. So if their RSBI was decent, their blood gas was decent, their chest X-ray, et cetera, were all kind of okay. But these neurologic patients could not follow commands. It didn't prognosticate very well for their success in weaning and extubation. Now we're going to pick up the pace in the presentation a little bit and just take a look at some excerpts from weaning protocols. They're not the actual protocol itself, but these would be critical elements. Patients should be assessed daily for readiness to wean. So a spontaneous breathing trial using mainly pressure support or another mechanism such as tube compensation, again 30 to 120 minutes. Some of the criterion, and I don't mean to say this is all of it, that the minute ventilation of 5 to 12, if it's a very large person, maybe it's a little north of 5 to 12, 5 to 14 or 15. Spontaneous, so really looking at the tidal volume of about 5, at least 5 mLs per kg of ideal or predicted body weight. So someone such as I'm about almost 5'10". I probably weigh about 180 kilograms, but so what we're really saying, somebody about my size, maybe a little bit less large than myself, you'd be looking at a spontaneous tidal volume in the mid 300s. Hopefully the respiratory rate is south of 35. Heart rate is less than 140. Some of the protocols say less than 120, but many times you'll see heart rates that are slightly elevated in the low 100s in the ICU just because of the stress that these patients are under. Saturation is north of 90. Some of the protocols say 92, but it depends on your patient population. And the RSBI south of 105, or sometimes they'll say between 30 and 100, something along those lines. The extubation criteria, so a NIF of at least -20, deliberate cuff leak of anywhere, depending upon the tidal volume, at least like low 100s, but some of them say 150 to 200, depends on the actual tidal volume that the patient's getting. And then looking at other things. Is the patient going back to the OR in a few hours? Where they be reintubated anyhow? Do they have an open belly? Do they have neurological problems? They cannot follow commands, like I alluded to in an earlier slide. So, you need to kind of look at, not just the NIF and the cuff leak, but, the total clinical picture, and collaborate, with the other clinicians, the nurse and the physician, in coming up with a plan to get the patient extubated or to rest them and, do it another day.
So this is an example of a simplified algorithm for a spontaneous breathing trial. And if you look at the top portion, the large rectangular box that's shown here, the process starts with assessing your patient's weanability. And some of the specific examples are mentioned. They're talking about overall clinical stability. And, again, some of this may be self-evident, maybe it is, maybe it isn't, but we're talking about clinical stability. You're asking yourself and you're asking the interprofessional patient care team, what's the patient's nutritional status? What's their fluid status? Are they grossly fluid overloaded? Have they just come back from the OR and they've gotten a lot of blood products and, IV infusions and things along those lines, which are going to take, probably 12 to 24 hours to find their way, if they're going to find their way into the vascular spaces and then perhaps, into the lungs and the pulmonary vasculature. Is the patient basically headed back for surgery at some point very soon? So, if they just, if you will, they're a trauma, they're intubated, but they're a complicated polytrauma, and it looks like they're going back to the OR, in 8 hours or 12 hours, that might be just an indication that they're not clinically stable. If they're hemodynamically unstable, so all these are examples of, if you will, deal killers. So in many of the electronic health records, what they'll do is they'll have a portion there. Was the patient assessed for a spontaneous breathing trial? Yes or no. If no, why weren't they? It's really something that's closely looked at. The default should be the patient should minimally be assessed for weanability. And if they're not weanable, that should be recorded. And if they are, let's kind of move a little bit further down this algorithm. So you're looking at other elements, what is their mental status like? This is also in the top portion of this. Their adequate height, oxygenation, you're looking at, pH and PCO2 and PO2, P to F ratio, oxygen index, and things along those lines. And then looking at their mechanics, if you will, the pulmonary mechanics. If when you actually go to put them on either like a tube compensation mode on the ventilator or a very low pressure support and PEEP, what are the mechanics like? And assessing them immediately, but also at various intervals, again, from 30 to 120 minutes. And then, have they met, in the next box down, have they met the readiness, to wean criteria? If they have, you're then, putting them on, a spontaneous breathing trial for at least, again, you're keeping them on, but for at least 3 minutes in order to get their rapid shallow breathing index. And again, just to quickly review, even though it is described elsewhere in this presentation, rapid shallow breathing index, the numerator, the top number is the, if you will, quote unquote, spontaneous respiratory rate, and the denominator or the bottom number is the tidal volume expressed as a decimal. So if the patient has a spontaneous breathing rate of, let's say, 25 per minute, their tidal volume is 500 or 0.5, that will be an RSBI of 50, or 25 divided by 0.5. If their RSBI is not good, you then actually resume the appropriate, full support, the assist control, the VC plus, pressure regulated volume control, etc., and allow them to rest typically for 24 hours. All right. The exception to that would be if the patient is sedated, but they're otherwise stable, and you assess them, let's say in the morning, you may actually want to lighten their sedation for later on and continue the process and perhaps do a second assessment in the early afternoon. Once that sedation has abated and they're starting to wake up, they, let's say, have a Richmond agitation station score of, let's say, -1 or 0, where they're either arousable or they're actually awake but fairly calm. And again, you're looking at your RSBI. Your RSBI, again, if it's north of 105, that would be an indicator that the patient is probably not going to successfully wean and certainly not extubate. If it's south of 105, it correlated better with their ability to successfully wean and hopefully be extubated. Now it's a scale, so if I would say 75 is probably better than 95 for most of our patients, unless what's causing the 95 or the 105 is agitation or pain. So you need this, obviously stabilize them for that as well. And then you're continuing, as I said, the standard of care is still pretty much 30 to 120 minutes, although some of the more recent data are saying that you're going to know in the first 30 to 60 minutes whether or not they're going to, they're going to do well. And then you're determining whether or not it was a successful spontaneous breathing trial, whereas all the criteria were met, including the RSBI, and then perhaps you're looking for a cuff leak. I say perhaps because most patients that have had that, let's say, have had the tube in for a short time, 12 hours, 24 hours, they're really not going to have a lot of issues unless it was a traumatic intubation. Still a good idea to do the cuff leak. There can be some false negatives. I say that like you've deflated the cuff, but you still don't get a leak. Sometimes you can get some gelatinous secretions that form around even a deflated cuff and don't permit a leak. So just be aware of the potential limitations. And then hopefully if all of the criteria are met, then they can be extubated. If they're kind of, yes, a lot of the criteria is met, but not quite all, but they've been on the vent for 12 days or so and they're headed for a trach, and let's say their RSBI is, in the 90s, around 100, something along those lines, then maybe they're extubated to an adjunctive device such as a high flow nasal cannula or non-invasive ventilation.
I sometimes hesitate in using the term optimizing, because that refers to can get no better, But really what we're saying is, again, making the patient the best version of themselves, so that we can give the weaning and hopefully extubation attempt the greatest opportunity to succeed. Ultimately, the patient succeeds because they get better, they get the heck out of the ICU, they get out of the hospital, hopefully they go home and, live their lives. But one of the approaches is, again, looking at the amount of sedation, looking at what's being used. So lighten the sedation and consider switching to a kinder form of sedation, such as Precedex. Just throwing that out there. Looking at fluid balance. So if a patient is extremely fluid overloaded, it's not a good prognosticator. You need to look at that carefully because some patients will actually have what's called insensible water loss. That they lose through sweating. Insensible simply means you can't measure it. So they sweat, things along those lines. With spontaneous breathing patients, it can be through their breath, things along those lines. But fluid balance is important. Proper nutrition, we now know it's extremely important, particularly for patients that have had significant trauma, major operations. They typically need a protein-rich diet, but they need to get fed. They need calories. And they need the right balance of macro and micronutrients in order to recover. And then permitting adequate recovery time from prior failed weaning attempts. Often it's a minimum of 24 hours of rest. Not everybody's the same, but if the failed attempt was because they were too sedated, then you can certainly try, sooner than 24 hours. But if it's something other than that, where they were working too hard, or even the sedation was not in the right, not in that sweet spot, it may be appropriate to wait, to wait either shorter or longer than 24 hours. Adjunctive respiratory care, so looking at things like bronchodilators, bronchial hygiene, suctioning, and things along those lines. There's some patients that, as soon as I extubate and my colleagues extubate, if they sound like they got a lot of secretions just right around where that cuff was, we'll just go down and nasotracheal suction them. When I say right away, once the tube is out and their SATs are okay and the things along those lines. And then looking at the airway optimization using mucus shavers or wiper caths, and we'll talk a little bit about those. And an ever controversial one is adequate staffing and resources. And if there's nurses, well, nurses are pretty mobile now too. A lot of them are going to traveler jobs, and there's a lot of movement that's going on right now for respiratory therapists and nurses. So staffing can be an issue. And there is a relationship between how good your staffing is, what your ratio of respiratory therapists to ventilator is. And yeah, you could stretch. I can handle 7 ventilators, but I can tell you right now, when you start giving me 10 ventilators, I can handle it, but they're not going to get weaned. There's stuff that's not going to get done as well. It may get done, and weaning is certainly one of those things. But so just to state the obvious, adequate staffing and resources is critically important. The strategy of using mucus shavers has been studied, not heavily, but it's certainly been studied. So we know that within hours after intubation, there's a biofilm that starts to build up on the inside of the artificial airway, the endotracheal tube. And that biofilm can do at least 2 major things. One of them is it can get thick enough where it can, if you will, reduce the inside lumen of an artificial airway. So many of you have taken out, let's say, for a trach tube, you've taken out intercannula, and you see all that crap that's sometimes caked up inside of it. You're changing the intercannula every 8 or 12 hours or whatever. So just imagine if that can get built up in a trach tube in a half a shift, in 12 hours or half a day, whatever. To think about what can build up in the endotracheal tube. So mucus shavers can be helpful in if you will, harvesting the biofilm and restoring the inside lumen of the artificial airway to its original diameter or circumference. The other thing that it can do is just by removing that biofilm, that what can happen is you reduce the chance that some of that biofilm will end up down in the lower airway and cause a pneumonia. So you have Pink Crowley in 2006, the EndoClear, and I'm sitting right now, but I'm not sitting or standing here saying you should use that, or you should use any of these devices, but determined that the device was safe and can help prevent ET tube lumen occlusion. Bordis in 2017, his findings were that in comparison to the EndoClear group, controls demonstrated a trend towards higher pneumonia rates. So controls had a higher pneumonia rate. Controls mean they didn't have the EndoClear. Scott in 2017 determined that, he and his colleagues determined that ET tube scraping can reduce airway resistance, but did not impact spontaneous breathing trial success. So that's kind of an important finding as well. It wasn't a huge study, but it's something to be mindful of. Now let's take a look at the categories of patient in relation to weanability. I think that's a word. I'm not 100% sure, but weanability, the ability to have a reasonable prospect of successful weaning and hopefully eventual extubation. So the quick wean, extubate, basically wake them up, assess, and then extubate. So it's quickie, choppy. That might be a post-surgical patients. Many times their biggest barrier is they still have anesthesia on board, they have some sedation on board, etc. Delayed quick wean, slow to clear to sedation, no spontaneous breaths in the morning, reassess them in late morning, early afternoon, and see how they're doing. Weaning, but extubation contraindicated, so diaphragmatic atrophy due to extended MV or mechanical ventilation and lack of optimization. Marginal extubation candidate, but they're headed towards a trach and a peg, which are imminent. So those patients may be, wean them conservatively, maybe wean them over a couple of days, and then when they're extubated, extubate them to an adjunctive device, such as a non-invasive positive pressure or high flow nasal cannula. And what the evidence says is if you're going to do that, so if a patient's a retainer, their gas is not perfect, they're retaining a little bit, but it's either compensated or nearly fully compensated, respiratory acidosis, maybe extubate them to BiPAP. If it's the oxygen, that's a little bit on the marginal side. Extubate them to high flow, or at least have it very nearby. Don't wait too long. because what the studies are showing is if you wait too long, they get buried in a hole and they can't dig out of the hole and they end up getting reintubated. No wean, no reassessment. Patients who should not be weaned nor reassessed the same day. So you got respiratory failure, sepsis, hemodynamic instability where they're on significant doses of vasopressors, alcohol withdrawal, and patients along those lines. Some of the contraindications to weaning and spontaneous breathing trials and maybe extubation. So inadequate oxygenation, spontaneous ventilation. So patients who have PEEP in north of 10, realistically, the PEEP during a spontaneous breathing trial, especially just prior to extubation, it really should be 5 to 8. Really shouldn't be, shouldn't really be extubating patients from 10 of PEEP or more, certainly more than 10 of PEEP. If their RSBI is north of about 100 to 105, if they're unstable, if they have unstable clinical status, so non-reversal of the reason for intubation. So they were intubated for airway protection, they still can't protect their airway, they shouldn't be extubated. Hemodynamic instability, a significant anemia, abnormal blood chemistry, sepsis, head trauma. I mentioned fluid balance irregularity before. And then, looking at if the patient is pharmacologically paralyzed. And you may say, well, that's an obvious one. Well, if you look through the literature, it's occasionally, it's not appropriately factored in. Imminent major surgery, this is the short list, but this gives you a general idea of some of the major issues that could preclude weaning, spontaneous breathing trials, and extubation. The key is to document these reasons. Today, electronic health records are pretty much a standard of care, and it's really a good idea to document those reasons. We actually monitor this very, very closely to ensure that our therapists and our nurses and our physicians, frankly, are being appropriate when it comes to, even if they're not weaning the patient, is that the reason for not weaning is documented and it's a sound reason. Some hospitals, including the one that I work at, they really look at, well, what kind of patients would actually wean, but they're not candidates for extubation. So it's kind of like this other subtle subclass. So your trauma patients who are stabilized but are scheduled for additional surgeries, patients on mechanical ventilation for extended periods of time who need to be built up, their diaphragm has and other respiratory muscles have atrophied. Patients unable to protect their airways. So a lot of these ones are these, patients who you just wouldn't even wean per se. Patients with insufficient or absent endotracheal cuff leak. The exception there is sometimes for patients who are intubated for 10, 12, 13 days, there's gelatinous secretions can form around the cuff. So sometimes when you deflate it, it doesn't, you don't really form a cuff leak. So you just need to be aware that sometimes you can get, if you will, a false negative, where the patient doesn't have a swollen airway. It's really a secretion issue. That's where some of your use of subglottic endotracheal tubes can be very, very useful. Neuromuscular patients with marginal weaning parameters. And then if there's like supportive care issues, as I mentioned, fluid balance, nutritional concerns, things along those lines may equate to, well, we can wean them, but they're not ready to be extubated. The X-ray is kind of marginal, the blood gas is marginal, it's a judgment call. So those are kind of the ensemble of things that need to be looked at. Another subclass are patients who fail the AM spontaneous breathing trial, but basically whose spontaneous breathing trial may not be warranted in the afternoon. So some patients you fail in the morning, for other reasons they're not awake enough, you want to try again in the afternoon. But there's other patients who no, you have enough to go on, just rest them. So persistent respiratory failure, whether it's oxygenation respiratory failure or ventilatory respiratory failure. Poor acid-base balance, the hemodynamic issues, significant anemia, intentional heavy sedation for things like alcohol and drug withdrawal. And again, if the patient's pharmacologically paralyzed. So in terms of attempting to position the patient, not physically position them, but clinically position them for the greatest chance of success. So enhancing extubation success chances. Pre-extubation assessment, adequate oxygenation ventilation, assessing their ability to protect their airway, no absolute contraindications that we've discussed previously, the pre-extubation optimization, reversal of the clinical reason, why they were intubated, fluid balance, nutrition, Post-extubation augmentation, again, looking at if they're kind of a marginal case, having the device, having the non-invasive ventilation device ready. A lot of the ventilators today, the invasive ventilators, can also double as non-invasive ventilators. So it's something that we do. We'll extubate, not having the whole BiPAP in the room. You can actually just use the 980 to ventilate them non-invasively. You're just going to make sure obviously you're in the right settings. And that you're using the correct interface. So you're using an interface that does not necessarily need to have a vent like you have. I'm talking about not a ventilator, but a kind of, the masks that we use with typical BiPAP, single limb circuits, their circuit is vented. It has an exhalation port, so it's vented. The mask is vented. It has one or more exhalation ports. Okay, when you're using a invasive ventilator to non-invasively ventilate a patient with a double limb circuit, you should not, and you do not have to have that exhalation port. So many times you either use a different interface or the interface should be adapted appropriately. So drilling down a little more deeply on some of the choices we have to extubate patients who may need some adjunctive help to bridge them from mechanical ventilation to total spontaneous breathing. So high flow nasal cannula. So Nye and others in 2017 determined that after extubation, high flow nasal cannula is a reliable alternative to non-invasive to reduce the rate of reintubation, as compared to just extubating them to an aerosol mask or a nasal cannula. Dillon and others also in 2017, the findings were that ventilated patients at risk for recurrent respiratory failure have reduced reintubation rates when with the appropriate use of high flow nasal cannula. So likewise, Zhu and others in 2013 determined that NIV, or non-invasive positive pressure ventilation, can reduce the need for reintubation and improve clinical outcomes as compared to invasive ventilation. Body determined that the clinician-dependent factors were linked to non-invasive ventilation failure. So the settings need to be right, the interface needs to be right, the patient needs to leave it on. The patient typically should not have restraints on when they're getting non-invasive positive pressure ventilation. They should not. Something to be aware of. Main thing is, because if they vomit, they need to be able to pull the mask off. So just a kind of a sidebar thing to consider there. Now let's take a look at a few cases. So the first case is really about interprofessional collaboration. 47-year-old male, post-trauma patient with multiple orthopedic injuries, is intubated and ventilated on assist control mode. All anticipated surgeries have been completed. The patient is now clinically stable. An attempt at a spontaneous breathing trial is not successful because the patient is not initiating breaths over the set rate, apparently due to heavy sedation. The physicians are not in the unit. What steps are the appropriate next steps for the RT and the RN to take? So the two of them, the respiratory therapist and the nurse, collaborate and say we really need to get the sedation down. So I'm kind of leading us in this direction. However, unless there's a protocol to actually reduce the sedation, if that protocol doesn't exist, the physician will need to be contacted to order that reduction in sedation and perhaps pain medication if they have that as well. So different systems are in place for that. There may be a physician in the unit. There may not be, but there's, the physician could be paged, or a lot of these electronic health record systems actually have a mechanism for sending a secure chat message or an instant message to the attending or resident physician and ask them to reduce the sedation so that we can get this patient starting to initiate breaths. As that happens, things like what we do is we'll extend the apnea, if you will, trigger parameter, the time. So the time interval typically defaults at 20 seconds. If the patient is on pressure support and they don't take a breath for 20 seconds, the full support will kick in. What we'll do is we'll elongate that when we're trying to wean certain patients to 30 to 60 seconds. The other thing we'll do is take the trigger. Like a lot of places, we use a flow trigger, and we typically will set that at 3, but for weaning patients, we may put that down to like 1.5 or 2 to make it easier for that patient who's now, the sedation's wearing off, they're now starting to wake up to initiate breaths. And for the apnea interval of 30 to 60 seconds, allow the CO2 to build up so that again they're stimulated to take a breath. This is case 2, wean, don't extubate. So we have a 39-year-old female post-head trauma patient recovering from her injuries during a sedation holiday and spontaneous breathing trial. She's now initiating 20 breaths per minute at a tidal volume of 330. And again, I didn't give you her parameters, but they seem really kind of respectable. If you were to do the, we'll do the Rapchella breathing index calculation in a minute. But her overall clinical status is stable. However, she's unable to follow commands. So what is her RSBI? Numerator is 20, denominator is 0.33. So this is pretty much very close to, dividing 20 by 0.33 is the same or very similar to multiplying it times 3. So her RSBI is around 60. That's a decent number. What factors would influence your recommendation regarding weaning and extubation? So the fact that she can't follow commands and that she has a demonstrable head trauma would suggest that probably not a good idea to extubate her. And again, there's different criteria used, but pretty much the standard of care would be wait until she can actually follow commands. Continue to wean her, but don't pull the tube because it sounds like she won't be able to protect her airway. Now this patient is a 69-year-old male, been on mechanical ventilation for 10 days for a COPD exacerbation. The RSBI during a morning sedation holiday is 102. So really, borderline high, almost over that threshold on 6 of pressure support. The saturation 94%, on an FiO2 of 40%, and the PEEP is +8. Patient has an adequate cuff leak, so that's really not an issue. Clinical status is otherwise stable. The ENT, so ear, nose, throat physician team, is scheduled to assess the patient for a tracheostomy over the next 2 days. So this patient is kind of headed in that direction. Is this patient potentially a candidate for weaning? Okay, so this is a patient who's not ideal, but they may be close to the best version of themselves. They may saturate at home at 92 or 93 or 94. So now they're at 94 right now with a little bit of a boost, FiO2 wise and PEEP wise. So they may well be a candidate for weaning. Let's give them a shot. If they successfully wean all morning on, let's say, +8 of pressure support, should they be considered for extubation? So what I'll say is this one's a little bit, not tricky, but something to consider. Our protocol is we want them down to 5 or 6 of pressure support. We want a decent RSBI on 5 or 6 of pressure support, okay? The caveat is if the patient has a small tube, if it's an adult patient with, let's say, a 7 tube, or, we typically don't use anything smaller than that unless it's, there's something odd going on we have a very active head and neck surgery team. They do a lot of cases, and occasionally these patients will come out with small tubes because they have a lot of swelling in their neck, they've had a tumor removed, something along those lines. But the bottom line is patients who have a 7, let's say it's me, and I have a 7 tube in place versus an 8, which would be closer to ideal. So in those cases, we'll actually actively wean patients on 8 or 10 of pressure support to overcome that additional resistance. However, in this case, I didn't say that. So it's like taking an exam with the NBRC. For any nurses in the audience, the NBRC is the National Board for Respiratory Care. They actually create, sanction, and grade the credentialing exams for respiratory therapists. All right, and one rule of thumb, one of the textbooks that I edit or co-edit is, if the NBRC didn't say it, don't assume it's so. So, this particular patient, we shouldn't assume that they have a 7 tube in place is really the moral of the story. So they're chugging along on a +8 of pressure support. Should extubation be considered? What I'd like to see, and I didn't say it in this case, is I'd like to see how they do on 5 or 6. and see if they're, if they're decent on that. So yeah, they can be considered for it. But in view of everything going on here, whether you extubate from 8 of pressure support or you bring them down to 5 or 6 of pressure support, they probably should be extubated to an adjunctive device. So that's the last part of this question is, that's the sort of the special consideration that needs to be factored into this particular equation. Now to illustrate another case or example that takes, one of our prior slides out of the abstract and puts it into the concrete. So these patients, no wean in the AM, no wean, no PM, afternoon weaning assessment. So in some cases the patient just needs the rest. Or in some cases, they just need to be kept on the ventilator. They have an open abdomen. They're going back to attempt to close it tomorrow for a washout tomorrow. They just need to rest. They're septic. They need to rest. They're hemodynamically unstable. They need to rest. Okay, so we have 47-year-old male, chest trauma. I'm going heavily on the trauma. It's my world. The two hospitals, the two tertiary care, hospitals that I've worked in have been major trauma centers. So it is kind of the world that I've kind of grown up in for the past 30 years. Except for about a 2-year period where I did home care. Pretty much 28, 29 years I've been working in trauma centers. The patient is mechanically ventilated, of course. Chest x-ray reveals bilateral ground glass appearance. PO2 is 65 on 80%, so they have a crappy P to F ratio. Really crappy. It's south of 100. PEEP of 14, so this is like, it's not a COVID-19 patient, but it could be. Peak airway pressures are 32. The plateaus are maybe 30, so patient has low compliance. Should this patient be assessed for ability to wean? Yeah, you can assess them for ability to wean, but they're probably, the second part is, should they be weaned? Why or why not? Because they have severe hypoxemic respiratory failure. They have, it looks like to be full-blown ARDS, and they just need to be, treated probably with kind, gentle mechanical ventilation with low tidal volumes of 5 or 6 mLs per kg, perhaps some permissive hypercapnia where you just allowed the patient be a little bit little bit acidotic with a respiratory acidosis in order for them to retain, their kidneys to retain hydrogen ions or bicarb, and then just get them over the hump, get them better. The reason why they were on the ventilator, try to reverse that and give their bodies time to recover. Should they be reassessed for the ability to wean in the afternoon? Probably not. They're not going to overcome their ARDS in 5 hours or 6 hours. What other therapies should be considered? I alluded to those very low tidal volume, probably for this patient, aiming to try to get their plateau pressures equal to or below 30. So I give the peak airway pressures of 32. I verbally said that the plateaus are 30. So that's borderline acceptable. But the bottom line is, if you can get the plateaus even to 25 or less, that's even more preferred. So you do something like that. Continue to use, liberal use of PEEP, but low tidal volume approaches. You also want to see if there's something else going on with this patient. If they could benefit from mucolytics, CPT, recruitment maneuvers, and things along those lines. These patients tend not to be great candidates for recruitment maneuvers. Because again, they have low compliance. It's not that they have atelectasis per se, but they have low compliance because their lungs are filled with fluid, not totally filled, but they have excessive fluid in them, and they're wet, they're stiff, and hopefully we can reverse this over time with the patient's own constitution and our care of them. This case is looking at a patient with marginal weaning parameters. RSBI is 102, weaning on 10 of pressure support for 9 hours. Over the past 3 hours, respiratory rate's been climbing. Now it's in the 30s, low 30s. Heart rate has been going up. Patient's diaphoretic despite suctioning bronchodilers and other interventions. And their pain and anxiety have been ruled out as the main cause of distress. What immediate action should be taken? This patient should probably be put back on full support. And what are some potential considerations for weaning over the next few days? Depending upon how hard you push them, you may find that some of these patients who weaned, I'm going to say excessively on day 1, it may take them several days to recover. And we can't understand. They weaned so well yesterday. Well, maybe they were pushed too hard. They developed diaphragmatic fatigue. You worked them too hard, and it's like a marathon runner who needs to. They ran the marathon. They trained for it. They did well in it, but now they need to take a couple days off. They have all that lactic acid buildup, etc. Some of the things that we need to be mindful of that I have not mentioned previously in this presentation are you get a patient who's on a trach collar, so the spinal injury is C4, 5, C6, intermittently weaning on trach collar during the day, repeated episodes of hypoxemia after 4 to 6 hours of trach collar. Think about trach collar. There's no PEEP with the trach collar. Shows signs of bibasilar atelectasis, which wasn't there, okay, and has been unchanged for the past several days. So it wasn't there a week ago. It's now unchanged over the past several days. What factors predispose this patient to hypoxemia and atelectasis? Their injury. So, if you recall, and I'm pretty sure that you all do, that the phrenic nerve, which innervates the diaphragm, emanates from C3 through 5. So this patient has a C4, 5. They may have some diaphragmatic activity, but it's inhibited in some significant way. So they can't take deep breaths. So we're trying to get them to a trach collar, but again, because of their inability to take deep breaths, they are exposed to atelectasis. The atelectasis can lead to things like hypoxemia, obviously can lead to pneumonia and other things along those lines. So what recommendations might help this patient in overall respiratory status is, perhaps, just very gradual wean, keeping them on the ventilator at night on PEEP. Sometimes these patients like positive pressure. They may actually, depending upon their pulmonary mechanics, they may end up being on some form of non-invasive or semi-invasive. So they may get something like BiPAP through a trach, or eventually, if they are able to get if they are able to get extubated, they end up maybe getting extubated to a BiPAP. And they end up, maybe their best version of themselves is they end up only needing BiPAP at night, not so much for obstructive sleep apnea, but just to keep them from developing atelectasis and to keep them from retaining too much CO2, particularly at night, because all of our respiratory drive will reduce at nighttime, but when someone has no reserve, such as a patient like this, it can be even more problematic. So they should be considered to be extubated to some form of, non-invasive ventilation, and then eventually, considering weaning them off of that. So let's look at some take-home messages here. Spontaneous breathing trial and weaning are important tools, or important goals, actually, and tools in optimizing ventilator patient care. However, they involve interprofessional collaboration and communication. Spontaneous breathing trials and weaning are resource dependent. So you got to have the proper amount of resources. You got to have if you're going to extubate patients to BiPAPs, you got to have enough BiPAPs. You got to have enough staff to actually be doing that. Your protocols are a form of a resource, that actually they often can represent an efficient use of resources. No single method for weaning and liberation from ventilation is infallible. The data are mixed. So it's important to keep an eye on the data. It's important to follow it, but understand that new research is being published all the time. However, some methods have stronger supportive evidence, research evidence, than others. So spontaneous breathing guidelines, RSBI, diaphragmatic issues, de-recruitment considerations, all need to be part of the mix. Use what evidence we have and stay tuned for more as research emerges on this stuff. So on this slide, I've just summarized some relevant resources, including this piece from Schmidt, which represents the official executive summary of the ATS, that's the American Thoracic Society's guidelines for liberation from mechanical ventilation in critically ill patients. A lot of the information that's in this presentation is based on those guidelines. My clinical assessment textbook has an entire chapter on assessing a patient in the ICU. So it has a lot of elements of assessment, hemodynamic assessment, looking at things like blood chemistry, but also it weighs very heavily on various indices for assessing our mechanically ventilated patients for the potential to be liberated from mechanical ventilation. Egan's Fundamentals, the third resource here, has several chapters on mechanical ventilation, the initiation, the monitoring and maintenance of patients on mechanical ventilation, the liberation from mechanical ventilation, and then chapters that talk about non-invasive as well as oxygen therapy, including high flow nasal cannula. And then Rich Calais' piece that really talks about the various articles that are out there and summarizes the results of what's been published on weaning and extubating patients, and looking at with an eye towards looking at best practices. Very, very good piece by Rich. With that, I want to thank you very much for joining us today. We hope you enjoyed the presentation. We hope that you come back to us. And again, we want to thank you very much, and I hope you have a great day. Bye.